All right, so I want to introduce Dr. Susie Gronski. She specializes in men's pelvic and sexual health. She's a licensed doctor of physical therapy, board certified pelvic rehabilitation practitioner, international teacher, and creator of online and in-person health programs to help men with pelvic pain become experts in treating themselves. Her passion is making you feel comfortable about taboo subjects like sex and private parts, and social stigmas aren't her thing, and neither is medical fluff. She provides real advice just like a friend. I loved this intro, and I'm so excited to have Dr. Susie here with us. She is an incredible speaker. She has a wonderful book, and we're really lucky. So I think everyone is in for a treat, and I'm going to turn it over to Dr. Susie.
Thank you, Jennifer, for that entertaining introduction. That was from circa a long time ago. So I appreciate you reviving it. Thank you very much. And hello to everyone who is joining us tonight. Thank you so much. As Jennifer has mentioned, my name is Dr. Susie Gronski, and I'm a doctor of physical therapy and an ASEC certified sexuality counselor and educator. ASEC stands for American Association of Sexuality Educators, Counselors, and Therapists. I am also the founder of a specialized comprehensive pelvic health care clinic in Asheville, North Carolina. We serve folks locally and online, and our team of specialists combines pelvic floor therapy, sex counseling, mental health therapy, and nutrition therapy to address a wide range of pelvic health concerns. In this session with you together, my intention is to provide a broad overview of pelvic floor physical therapy for men post-cancer. In particular, I will be addressing the general adverse effects of cancer on bodily systems and reviewing bladder, prostate, testicular, penile, and colorectal cancers. It's worth noting that referrals for pelvic therapy, particularly from the oncology team, are uncommon. Despite the need for support in addressing bladder, bowel, and sexual dysfunctions that may arise from cancer treatment. So I hope that more individuals gain better access to the rehabilitative support and care that they need. I also want to mention that the language I will be using throughout my presentation closely reflects the patient population that I work with. And so I will be intentionally using terms like male and female, man and woman. But I do want to acknowledge that there is still progress to be made in supporting those with transgender or gender expansive identities, supporting transgender men and non-binary individuals. Okay. So we will be going through the potential physical and emotional sequelae of various cancer treatments on the bodily systems, including surgery, radiation, chemotherapy, immunotherapy, hormonal and biological therapies. And so the systems overview will include the musculoskeletal system, neurological, cardiopulmonary, lymphatic, integumentary, genitourinary, immune, and psychosocial realms. It's important to name that any and all types of cancer diagnoses, treatment, and treatment sequelae have the potential to disrupt activities of daily life, including vital functions like bladder, bowel, and sexual function and enjoyment, as well as cause significant emotional and psychological distress. So the musculoskeletal system. With cancer treatments, the potential adverse effects include, but not limited to, decreased joint mobility, scar tissue and adhesions, tissue atrophy or tissue loss, and that can include muscles, bone, nerves, etc. Decrease in muscle strength, decrease in balance, endurance, risk for osteoporosis, bone fractures, deconditioning, and pain. And it's worth noting that some of the effects specifically of androgen deprivation therapy that may sometimes be used as a treatment for, in particular, prostate cancer, this reduces testosterone levels. And these effects will include erectile dysfunction or difficulty, decreased sexual arousal and reduced libido, muscle loss and atrophy, and increase that person's risk for falls, osteoporosis, and fractures. In fact, it has been said that 1 in every 5 men will experience a fracture within 5 to 6 years of this particular treatment. Moving on to the neurological adverse effects with cancer treatments. The big one here is chemotherapy-induced polyneuropathy. And this is damage to the sensory, the motor, or the autonomic nerves. So you have sensory nerves that supply our ability to feel things from our skin, motor that supply the muscles, bones, and joints, and then the autonomic nerves, which are nerves that regulate everyday function, bodily functions that you don't think much about or have to think much about, like digestion, your heart rate, your breathing, pooping, peeing, and in some degree, sexual arousal. So any damage to these nerves can cause significant distress in this area. Chemotherapy-induced polyneuropathy is typically caused by neurotoxic drugs that are used in chemotherapy. And some of the symptoms may include numbness, tingling, nerve pain, decreased positional or your ability to sense where your body is in space, vibration, temperature perception and awareness, and altered touch sensation. Autonomic dysfunction is a branch that can be put underneath that chemotherapy-induced polyneuropathy. So autonomic dysfunction it occurs when any of the autonomic nerves are injured or damaged. And this could be from surgery, from radiation, or chemotherapy. The side effects of autonomic dysfunction are many, and that can include changes in the blood pressure or something that we call orthostatic hypotension, which is a sudden drop in blood pressure with positional changes. So whether from lying down to sitting or sitting to standing. Constipation, altered bladder, bowel, and sexual function in numerous ways, which we'll get into more later in this presentation. The inability to sweat normally, heart arrhythmias, dry eyes and mouth, decreased visual acuity. Ototoxicity is common with cisplatin chemotherapy treatment, which is typically used in advanced cancers of bladder, ovaries, and testicles. And this involves the ear or the auditory nerves. It can also be a result of surgery involving anything to do with the head, the neck, or the nerves of the ear and ear canal. Symptoms of ototoxicity include hearing impairment or loss, balance issues, postural imbalances, ringing in the ears, dizziness, a sense of fullness in the ears, and diminished fall reflexes. So your ability to be able to catch yourself if you feel that, or if you sense that you're falling. Phrenic nerve neuropathy. The phrenic nerve is a nerve that originates from the spinal nerve roots of your neck. So C3, 4, and 5 keeps you alive. That was an acronym that we use in medical school to remember this nerve because it's so important. And it keeps you alive because this nerve innervates or supplies the diaphragm, which is your breathing muscle. Any injury to this nerve can impact your breathing function and mobility. And because the diaphragm acts synergistically with the pelvic floor muscles, it can also negatively impact the function of your pelvic floor. And we'll get into more of what is the pelvic floor just a little bit. You can also experience nerve damage or sensory loss or impairment, as I have mentioned. It's also worth noting here the impacts of radiation fibrosis on nerve tissue. It can cause injury to the vasculature, the lining of the vasculature, oxidative stress, and induce a pro-inflammatory state in the body. This can also result in tissue loss or atrophy, which can also impact neurovascular innervation. And that can certainly lead to pain dysfunctions, sensory loss, or neuropathy or neuropathic pain as a result of injury to the nerves in this area. Cancer-related cognitive impairment is a sequelae of systemic treatments like chemotherapy, surgery, and/or radiation that has been postulated to be influenced by a hyperactive immune response or inflammatory response systemically. Some of the symptoms include memory impairment, difficulty concentrating and focusing, slow to process, diminished executive function like reasoning and problem solving, planning and execution of tasks can be challenging. Also on this list, which goes hand in hand with some of the things I named in the musculoskeletal section, is decreased balance and also coordination. Cardiopulmonary adverse effects of cancer treatment may include cardiotoxicity, which is an adverse effect from radiation toxicity, chemotherapy, and immunotherapies. Some of this may include cardiomyopathy, which is a disorder that affects the heart muscle, pericarditis, which is inflammation of the sac that surrounds the heart muscle, acute coronary syndrome, which is a sudden reduction or a blockage of blood flow to the heart, and cardiac pump dysfunctions, which is disruption of the heart pump mechanism itself. There's also an increased risk of a DVT or a deep vein thrombosis or a pulmonary embolism. And in fact, the frequency of a DVT or a pulmonary embolism is at a higher frequency in persons living with and beyond cancer than their non-cancer population counterparts. There's also an increased risk of blood clots with surgery, chemotherapy, hormonal therapy, blood transfusions, central venous catheters placed in, etc. Blood pressure changes, which I've talked a little bit about as far as orthostatic hypotension, which is the sudden drop in blood pressure with changes in positional movement. But you can also experience hypertension or high blood pressure. Anemia, which is the lack of red blood cells or hemoglobin, and it's the protein that has iron that transports oxygen to tissues. And pulmonary toxicity, such as pneumonitis, which is inflammation of the lung tissue, can cause significant chest pain, belabored breathing, decreased endurance, and deconditioning. And lastly, cardiopulmonary edema. And this is when the heart is unable to pump enough blood out of the blood that it's receiving from the lungs. And so it's overworked and overtaxed, resulting in backup of fluid in the lungs and in the heart. Oh, I'd also like to mention that in this cluster of effects, there's also a potential for having low potassium amongst other micro nutrients, malabsorption, and other factors that lead to that, which can contribute to muscle fatigue, cramping, spasms, and abnormal heart rhythms. Okay. So the lymphatic system, what is the lymphatic system? Well, the lymphatic system is part of the cardiovascular and the immune system. Its role is to maintain fluid equilibrium in the body to optimize immune function, and it fosters balance within the tissues. So secondary lymphedema is something that can often occur, which is the accumulation of this protein-rich fluid that the lymph system is struggling to transport and move throughout the body. Lymphedema is caused by any insult, injury, or obstruction to a specific region of lymph tissue in that area. So things like dissection, biopsy, or any other impact on that lymphatic system can contribute to genital or pelvic congestion, compromised healthy tissue and immunity, and it does affect all body systems because just like the cardiovascular system, the lymphatic system works in tandem with your vascular system as well, and also with your immune system. So the integumentary system, which is your skin is the largest organ in the body, and it is directly and indirectly impacted by cancer treatments. And some of those can include radiation burns, dermatitis, which is skin inflammation, skin color changes like hypopigmentation, redness, frailty and thinning of the skin, dry, flaky, itchy skin, scars and adhesions. And this can all contribute to a reduced immune barrier, easy bruising and bleeding, hair loss, and nail changes. And the immune system. So certainly the immune system is a big system that has many adverse effects following cancer treatment or potential cancer treatments. And that's the overall decrease in the immune function. So cytotoxic chemotherapeutic agents do impact the immune system systemically. This can cause systemic inflammation, increased propensity for infections and delayed wound healing, decreased white and red blood cell count, decreased cognitive function and focus and fatigue. And in particular, the disruption of the integrity of the skin or the organs or any local tissues by radiation triggers an inflammatory response that can cause local and systemic inflammation. And in addition to inflammatory responses also happen within the mucosal lining of all of the body, so hollow organs inside your mouth, around the anus, that can also be impacted as well. And a word to note about specifically androgen deprivation therapy, again, which is most commonly used, can be used with prostate cancer treatment, is the diminished immune function from that type of therapy, which can contribute to delayed wound healing and tissue healing as well. And then we can't forget about the impact on the actual skeletal system, because with many of the chemotherapy treatments, there may be myelosuppression, which is bone marrow suppression, and bone marrow is what produces our red blood cells and white blood cells, and so that may lead to neutropenia, or what we would call low white and red blood cell count. Okay, so the gastrointestinal adverse effects may include cachexia, which is a significant or severe weight loss and muscle mass loss, which is a combination of metabolic consequences that occur as a possible consequences of cancer treatment, severe malnutrition, weakness, and loss of skeletal mass. And certainly loss of any skeletal mass anywhere on the body is going to certainly impact urinary and bowel function and sexual function. Radiation gastritis, enteritis, and colitis. So radiation gastritis is injury to the stomach tissue due to increased gastric radiation, which can include esophagus, stomach, pancreas, and the biliary duct, which is the tube that carries bile from the liver and the gallbladder through the pancreas into the small intestines. So any radiation in that area can cause stomach tissue injury or inflammation. And then radiation enteritis and colitis are any disorders that can alter the function of the small intestine after radiation to the abdomen, pelvis, and or rectum. It causes significant inflammation of the lining of the colon, and it does change the mucosal or the inside lining of these tubes, impacts nerves, blood flow, can result in scarring and adhesions, strictures or narrowings of these tubes, fibrosis and malabsorption. Constipation and diarrhea can certainly be an adverse effect here, an increase in bowel movement frequency. Hernias. So hernias due to the weakness or disruption to the abdominal wall or the intra-abdominal pressures. And this most likely shows up if there is an ostomy or a stoma, which is a surgically made hole within the abdomen. Ascites, which is really just a fancy term for excess fluid in the abdomen. And this is really due to hypertension within the venous system around the liver. Fecal incontinence, anal discharge, and then chronic dysmotility, which is smooth muscle impairment to the intestine. So smooth muscle are not like skeletal muscle that when you make a fist, squeeze your bicep. Smooth muscle is typically what is lined in hollow organs and not under voluntary control. So that dysmotility can impact the smooth muscle lining, changing bowel and intestinal function. Okay, we'll break up some of that intense review because it's important one of the reasons why I found it important to describe the overall systemic and bodily effects of cancer treatment is because any and all of those treatments have the potential to impact bladder, bowel, and sexual function. So really, it's not just pelvic cancers or pelvic-related cancer treatments, but whole person treatment, to whole person impact around these treatments. So before we review the potential adverse effects of the genitourinary system, I thought it would be helpful to get an understanding of the pelvic and genital anatomy. So I'm going to actually stop sharing my screen for a moment. Great. So that I can show you this male pelvis model that I have here. All right, so to orient you, because I know some of you may not have this knowledge in your toolbox. If you're sitting right now, the two parts of the butt that you're sitting on are these two right here. These are called the ischial tuberosities or the sits bones. On top, so if you were to place your hands on your hips, you have the wings of the ilium or the pelvis. In the back, you'll see that this is the sacrum or the end of the spine. The rest of the spine is stacked up here, so you'll have to imagine that. So your low back, middle, and upper back. And then these little indentations here, this is a socket, and that's where the long bones of your thigh bone connect to, that's your hip. And everything in between your butt bones here is called the perineum. And this includes the urogenital pelvic floor muscles, which you can see actually are connected to the bulb of the penis or your erectile tissue. And then you have this muscle here, which is the external anal sphincter. And that muscle, we've all used it before at some point. If you hold back gas or try to do that, that's the muscle that you're engaging. Other structures you'll notice here as well are the scrotum and the testes with the spermatocord. And then the muscle. So this is where all the muscle and tissues are dissected. And you can see the testicle and the epididymis and the neurovasculature. On this side, you have the muscle and the other tissue over it, and the nerves that you see coming, actually, they come all the way from your back. Before I get too ahead of myself, I have to say that this model is not just 100% accurately scaled to everything that lives here. It is an educational model, so there's a lot of things that are missing. So going back to the perineum, these muscles here in particular, these urogenital pelvic floor muscles, they aid in sexual appreciation. And what I mean by that is that with ejaculation, these muscles involuntarily and rhythmically contract and relax to expel fluid from the penis. And because you have nerves, which are on both sides, that supply this area, motor, sensory, and autonomic. This is not a quiz, but to remind you, motor is these nerves help muscles contract and let go. So they give that motor command or that electrical signal to do that. There's also sensory. So these nerves are sensory, meaning when you touch the genitals or stimulate the genitals, you feel touch. And these are the nerve receptors that are picking up on different kinds of touch in this area. Vibration, temperature, soft, firm, hot, cold, etc. And these nerves, when these muscles squeeze, or when you squeeze these muscles, they actually activate. There's some sensory signaling that goes on that helps to activate a complex symphony of events that can occur, especially as an erection or ejaculation happen, because these are spinal reflexes. So if we just simplify this to more a very, very mechanical, simplistic way, if there's any genital arousal, physical and or psychological, because both matter, when we're talking about sexual arousal, these nerves that actually come from the pudendal nerve, that come from your back, send signals up to your spinal cord and then up to your brain. And then a motor response happens. So the nerves from the spinal cord send signals via these nerves to the muscles and to the erectile tissue for an erection and or for ejaculation. So as you can see, if there's any injury or impairment to the neurovascular structures in and around this area, it has the potential to impact significantly sexual function, but also urinary and bowel function as well. Okay, so I think I mentioned superficial pelvic floor muscles, external anal sphincter. You might be wondering, what the heck is this? So that's the levator ani. That's the deepest part of the pelvic floor muscles. And let me show you that next. So that's the pelvic floor, the pelvic diaphragm. That's the deepest part of the pelvic musculature. And these muscles extend from your pubic bone all the way to your tailbone. And they support your bladder, prostate, and rectum. And let me put these structures back in their home so that you can see exactly what I'm talking about. Right here. So bladder, prostate, and right there in the back, right there is the rectum. And the deep pelvic floor muscles aid in support and stability and also sphincteric control, meaning continence control. Help you pee and poop, keep poo and pee in, also let it out when you want to. These muscles here that I forgot to mention, they also aid in continence control because this group also involves the urinary sphincters as well. And I will show you that in just a second because we're going to go inside the pelvis. So to orient folks, here, this is the front of you, and this is the back. So that's the sacrum. And these are the deep pelvic floor muscles that I was speaking of: rectum, prostate, bladder. External urethral sphincter will live here, and that is the muscle that you use if you want to hold back pee. That is under your control, meaning skeletal control, just like as if you would do a bicep curl. And then this muscle up here, that's at the bladder neck. So bladder, prostate, rectum, hollow parts of the organs that you're seeing. The internal urethral sphincter is not under your control. It is under, it's smooth muscle, and that's under the autonomic nervous system, which is the nervous system that operates without you needing to do anything. So that is the inside anatomy visualization of what's going on here. Other things to note are the vas deferens, which is this tube, this little clear tube that you see here. It's not really clear in the body, but on this model, it's clear. It actually takes sperm. This is where sperm travels up through the spermatic cord, goes back behind the bladder, and then places it here in the ejaculatory duct for when appropriate. So that's that tube. And then one more layer, I take the organs away, you can see that there's a lot of there's an artery, the common iliac veins and arteries, and then the sacral plexus or the sacral nerves, again, that come together and that create that yellow nerve right here, which is the pudendal nerve. S2, 3, and 4 keeps your poop and pee off the floor. So again, if anything is going to disrupt the neurovascular, musculoskeletal, or organ systems here, you have the potential of having some unwanted side effects of bowel, bladder, and sexual dysfunction. There's so much to anatomy, you all, and I wish I had so much more time with you. There's that nerve that I just mentioned also supplies the penis, you can see here. And not shown in this model, but there are a set of nerves around the prostate called the cavernosal nerves that supply the erectile tissue. So if there is any change in and around the prostate, like with a prostatectomy, then there may be a potential issue with sexual dysfunction because the injury to the nerves in that area. And even if it was a nerve sparing surgery, there is still inflammatory responses in that area and neuropraxia, which is injury just from the actual procedure itself, that it does take time for nerve healing. But these nerves to the penis that come from that pudendal nerve are preserved in that situation. So there's a lot that we can work with there. All right, so let me put my pelvis back together. Because also worth mentioning, also worth mentioning is the abdominal tissue in the front. Lots of the nerves that supply the pelvis, the lower body, the genitals, and the pelvic floor do come from the lower back, lumbar, and sacral region. And these nerves do course through the abdominal tissue. And your digestive organs, which are not shown here, but they sit right on top of your pelvis. So again, any digestive disruption or potential cancer treatments that influence the digestive system or any neighboring areas can certainly influence what's happening in the pelvis. Okay, I must be mindful of time. There's so much that I want to share with all of you, so little time. Okay. Let me share my screen. All right. So the potential adverse effects of the genital urinary system, which I've mentioned some of them already in the anatomy review, but pelvic radiation disease is a big one. And this is what directly is going to impact pelvic muscle structure and function. It can result in weakness and pain, muscle spasm, diminished coordination, and urinary and or bowel control. It can directly impact the pelvic organs themselves, like causing bladder fibrosis, which is the inflexibility of the bladder. And it can cause reduced storage capacity, filling capacity, create urinary urgency and frequency, and urinary incontinence. Any radiation around this area can also impact the hip, pelvis, low back joints and tissues, which can cause restrictions impacting sexual intimacy, function, positions, comfort, bladder, bowel capabilities, etc. And certainly any radiation to this area directly can impact fertility, or the testes, which can impact fertility. And I already mentioned the direct impacts on that pudendal nerve, which is, remember, S2, 3, and 4 keeps your poop and pee off the floor. This nerve right here, that's coming from the sacral spinal nerve roots, S2, 3, and 4. Any injury to this area can certainly impair pelvic floor muscle function, sensation. It can even decrease your ability to recognize that your bladder is full or filling. It might lead to incontinence where you don't know it's even happening. We call that insensate incontinence, and reduced genital sensitivity and anorgasmia, which is difficulty or inability to achieve orgasm. And certainly any functions that involve tubes or movement of fluid, if there's any scars or fibrosis or strictures, which is narrowing of any of those tubes, including the ejaculatory duct, can also result in erectile difficulty, ejaculatory disorders, etc. Bladder irritation, I've named some of that already, but just to offer a few more, anything related to increased urinary frequency or daytime urination, painful urination, urinary hesitancy, feeling like you haven't completely emptied your bladder, and nocturia, which is urinating, having to wake up at night to go urinate more than 2 times in the night. Neurogenic bladder, which is the disruption of neurological signals and the feedback loop from the bladder to the spinal cord and or pelvic floor muscles that impact urinary reflexes, awareness, and function. Neurogenic bladder situations can also result with any treatment related to brain tumors or brain cancer as well, because that's a feedback loop from a top-down perspective of the brain, spinal cord, and then to your bladder. I mentioned urethral strictures before, but it's a narrowing anywhere along the urethra. So anywhere that there's a narrowing that fluid is having difficulty moving through can create lower urinary tract symptoms. Urinary incontinence, certainly we've talked about that a little bit. And some of the risk factors around that have to do with any type of changes within the prostatic tissue themselves, like an enlarged prostate or pelvic surgery, radiation, especially if it's combined with any other therapies like targeted local radiation therapy or brachytherapy. And talked about, Peyronie's disease. Okay, so Peyronie's disease is actually the potential of having adhesions or plaque formation, usually on the dorsal or the side that is closest to the belly. And that can be anywhere in this region. It can be anywhere in the penile tissues, but most commonly it's in this general vicinity. And that's really an accumulation of plaque or scar adhesions that can form and create a penile deformity or a curvature, an upward curvature, most noticeable when erect, but depending on disease progression, it can be palpable when flaccid. And any type of neurovascular changes in this area, surgery, or diminished healthy blood flow to this part of the body can certainly increase one's risk of having adhesions and plaque formation, such as Peyronie's disease. Okay, and sexual dysfunction I've mentioned, but certainly can range from pain with sexual function, painful erections, ejaculation, erectile dysfunction, decreased arousal, libido, motivation, etc. Ejaculatory disorders I had mentioned as well, and lack of physical and emotional motivation or arousal. And then the psychosocial aspects of this all, certainly besides the daunting physical challenges that individuals face navigating cancer, post-cancer treatments with and beyond cancer, can also grapple with profound psychological, emotional, and relational obstacles. And this includes depression, anxiety, sadness, fear and vulnerability, financial stressors, loss of spirituality, sense of self, sense of purpose, relational challenges, changes in roles, relational roles and dynamics, and caregiving roles, decreased physical and emotional intimacy, cancer defining one's identity or changing one's identity, challenges to self-esteem, challenges to sexuality, and certainly a lack of rehabilitative care and support. So this slide is just I think a nice visual overview of the summary of the adverse effects on the human person, their engagement with themselves, their body, and the world of the genital, particularly the genital urinary adverse effects. But I won't go too much into this because I've already given that broad overview, but everything can impact certainly what is happening in the pelvis and the person who lives with the pelvis, of course. Okay. We'll move on to discussing some of the specific oncological diagnoses and then how pelvic therapy addresses or supports persons living with and beyond cancer with potential bowel bladder treatment sequelae. So I'll be discussing bladder, prostate, testicular, penile, and colorectal anal cancer kind of in one section there. So regarding bladder cancer, according to the American Cancer Society, bladder cancer is 4 times more common in men than in women. And the rates of new bladder cancer diagnoses and deaths from bladder cancer are actually dropping and trending in a lower direction, which is great. So as far as the potential treatments for bladder cancer, that's transurethral resection of the bladder tumor. So specifically going in and resecting a specific part of the bladder in the tumor. That may include partial or radical cystectomy, which is removing some of the bladder tissue or completely the entire bladder, which also will include, this is where I love this model a little bit here. If I take the bladder out, it will include the seminal vesicles, the prostate, and any of the other tissues related to the bladder, and sometimes the rectum. Chemotherapy, external beam radiation, and immunotherapy. So potential adverse effects of bladder cancer treatment specifically can result in bladder scarring, decreased bladder volume, infections, urinary urgency and frequency, pain with urination or pain otherwise, fibrotic tissue changes of the bladder itself, so reduced filling capacity perhaps, urinary incontinence. And for men who have surgical resections, Sometimes that can cause nerve damage, which any nerve impact or injury in this area can result in sexual dysfunction, erectile difficulty. Any removal of the prostate gland, so like in a radical cystectomy, where the full bladder is removed, the prostate and the seminal vesicles, and I mentioned sometimes the rectum or part of the intestine is sometimes even used to create a new bladder, or what we would call a neobladder, that can result in a dry orgasm or dry ejaculation. And then other potential complications here may include stoma problems. So if there is an ileoconduit, which is the small intestine is used to divert urine, and or an ostomy for urine collection. Any intestinal reservoir problems and stoma problems can be part of this picture as well. Prostate cancer. So according to the American Cancer Society, 1 in every 8 will be diagnosed. And it is the most commonly and frequently diagnosed cancer in the United States. And it is the second leading cause of death in men in the US. And it has been said in literature that 3.1 million men living with a history of prostate cancer and potential treatment-related sequelae. So the treatments here are active surveillance, transurethral resection of the prostate or a TURP, partial or radical prostatectomy, radiation, hormonal therapy, chemotherapy, or immunotherapy. And certainly the effects here can be urinary incontinence, urethral strictures, which again are any narrowing of the tube that can impact urinary flow and continence, radiation fibrosis, radiation cystitis, gastrointestinal effects with chemotherapy, low back pain, pelvic pain, surgical incisions, scar or fibrosis that can cause pain with urination, erections, defecation, or ejaculation, neurovascular damage that can result in certainly erectile dysfunction or ejaculatory disorders, penile shortening because of the reattachment of the urethra to the bladder, typically will cause a very small change in penile length. But if there is any adhesions or fibrosis or scarring, such as in Peyronie's disease, that can result in penile shortening or reduced length, and decreased arousal, anorgasmia, again, difficulty or inability to achieve orgasm, and significant mental distress. Any and all of these can cause significant emotional and psychological distress. Okay. Testicular cancer is the most common cancer in white males between the ages of 20 and 34 years old. 1 in every 250 men will develop testicular cancer at some point in their lifetime, again, according to the American Cancer Society. And the treatment here is an orchiectomy, which is a complete removal of the testes itself, which sometimes includes the spermatocord and the lymph nodes. Retroperitoneal lymph dissection, which is a removal of the abdominal lymph nodes as well. External beam radiation, or a combination of the retroperitoneal lymph node dissection. Chemotherapy can be a treatment here if there's metastases or reoccurrence. Autologous stem cell transplantation, which is a type of regenerative medicine that replaces a person's stem cells that were destroyed during chemotherapy or radiation. And the adverse effects are fertility issues, but generally in an orchiectomy, it does not prevent fertility. So if you have one testes, that you can still conceive. It's rare to have nerve damage to nerves involved with ejaculation, which can cause retrograde ejaculation, but that can happen, especially if it's a nerve-sparing approach. Sometimes the treatment will include a bilateral orchiectomy, which in this case will result in an orchiectomy, which will, in this case, cause infertility, decreased sex drive, erectile dysfunction, fatigue, hot flashes, loss of muscle mass, and this is due to decreased testosterone. Testosterone is produced by the testes, and most often folks will be on some hormone therapy. Sometimes a prosthesis can be placed, an egg-shaped saline prosthesis implanted into the scrotum if the person desires. And certainly, again, any surgery or radiation can impact bowels, including constipation, diarrhea, malabsorption, and obstruction. And penile cancer prevalence is very rare. It's less than 1 per 100,000 men diagnosed globally, and 95% of penile cancers start as squamous cell carcinoma of the foreskin and glands. And treatments are laser ablation, so local laser ablation to remove the tumor, or glands resurfacing. In some cases, there is a partial or full penectomy, which is a removal of the penis itself, chemotherapy, and radiation. Adverse effects of this particular cancer treatment, certainly anything that can impact the bladder, so overactive bladder, difficulty emptying, difficulty emptying the bladder, pain, sexual pain, pain anywhere in that area, erectile dysfunction, loss in sexual function and desire and satisfaction, anorgasmia, physical deconditioning, penile shortening, scarring, Peyronie's disease, decreased arousal and motivation, and mental distress, amongst many others. And lastly, colorectal cancer, which is the 4th leading new cancer diagnosis in the US. It's actually considered the most preventable, but the least prevented, which is interesting. And trends are leading in more of a younger population when it was once considered to be more prevalent in the older population, 45 years old to 50 instead of 65 and above. It is the second leading cause of death in the US, which is more than prostate and breast cancers. And the treatment includes a polypectomy, which is local resection of the tumor within the intestines and possibly lymph node removal, or a colectomy, which is the primary surgery used to remove colorectal cancer lesions. They remove the diseased portion of the colon and then reattach it back to healthy tissue. Rectal cancer is similar approaches as far as treatment. This will include also the anal area. So there can be a transanal local resection, which is removal of tissue in the anal area itself or in the rectum itself. There are 2 types of procedures that are here. So transabdominal surgery, which is a removal of the rectum, the fat, and the lymph nodes, or a lower anterior resection, which is a surgical procedure that removes the middle and upper rectal cancers. And this involves removing of the rectum and of the sigmoid colon as well. And for time's sake, oh my gosh, there's so much. I did want to talk about the APR of the abdominal perineal resection, because with that particular procedure for colorectal cancer, the rectum is removed along with the anus and the pelvic floor, which is the levator ani, and a permanent colectomy is performed, and there is no bowel control after this particular surgery. And a cluster of effects, particularly low anterior resection syndrome, which is a cluster of symptoms resulting from these particular potential cancer treatments, is when there's a total or partial resection of the colon, it can consist of fecal and gas incontinence, urgency, frequency, difficulty with bowel emptying, inconsistent stools, loose stools, skin irritation, neuropathy, rectal anal stenosis, and lymphedema. I've already touched upon pelvic radiation disease earlier, and certainly insensate fecal incontinence, or just the ability not to sense that there's gas, liquid, or stool. So sensory deficits in that area as well. And short bowel syndrome is when the small intestines are shortened and or damaged in some way. Okay, so pre-rehabilitation. So important here because it has been shown to be very effective for gastrointestinal, colorectal, breast, prostate cancer populations. And here are all the potential benefits of getting support from your rehab team: decreased post-op complications, reduced hospital stays, reduced overall healthcare costs, speed up continence recovery, build functional tolerance and endurance, anxiety coping strategies, risk reduction with more physical activity as far as recurrence of cancer rates, foster support through building community and education, lots of resource sharing, continence care supplies, expectations, pain management, and so again, encouraging activity. I can't stress that enough, because 50%, so this is just one statistic, but 50% of people with, I'm going the wrong direction. 50% of people with post-colorectal cancer surgery will fail to return to pre-op physical activity levels 6 months post-treatment. And again, exercise is something that is, especially also in our field as far as rehabilitative medicine, not really stressed enough, in my opinion. And so exercise has so many potential benefits pre as well as post cancer treatment or cancer diagnoses. There are no specific exercise protocols when it comes to pre-rehabilitation, but there is encouragement to follow the American College of Sports Medicine guidelines that say 150 minutes of moderate intensity, if able, of aerobic activity every week, and then working out your big muscle groups, upper body and lower body, at least twice a week, or some form of that. Something is better than nothing. And a word about pre-rehabilitation for prostate cancer urinary outcomes. There are several small sample size studies that did show some positive effects with pre-op pelvic floor muscle training. So that's great as far as continence recovery. It may also potentially speed up continence recovery return sooner than later. So the pelvic health evaluation, what does it look like? First and foremost, it's permission, compassion and consent, and permission, extended consent throughout, always asking permission to even address sexual health concerns and the importance of what they might be for an individual. Then we have the intake, which certainly involves a current review of that person's concerns, stressors, past medical history, review of any imaging or of the urogenital and sexual organs, a full systems review. As you've probably noted from this presentation earlier, there are so many systems that are involved that we need to be looking at and reviewing. Past and current treatments, medications and supplements, lifestyle factors such as sleep, exercise, stress, recreational and medical drug use, and specific questions around bladder, bowel, and sexual function will be asked. And in particular with sexual health, a little caveat here, I am a sexuality counselor and educator, and not all physical therapists or pelvic floor physical therapists are trained to discuss openly sexuality health concerns. So they may or may not ask these questions, but if you do have someone who has sexuality training, then you can expect that there'll be at least a question to say, hey, is it okay if I ask you how your cancer diagnosis or cancer treatment has impacted your sexuality? And that questioning may be around arousal levels, libido, pain with sexual activity, stimulation, erection and ejaculation function, anal touch play or penetration, and your ability to reach orgasm or climax, or experience pleasure, etc. We do screening for psychosocial issues. We check vitals like your blood pressure, your heart rate, and your respiratory rate. The orthopedic assessment, because we're dealing just with the pelvis, we're also dealing with you as a whole person and an ecosystem. So we do address the abdomen, the hips, the pelvis, the upper and lower bodies for strength, endurance, and mobility. We take into consideration anything or any cancer treatment that may impact mobility function, breathing mechanics that may influence the pelvic floor. And certainly that includes scar mobility assessment from simple to complex functional movements like trunk rotation, stretches, and also mobilizing tissues with our hands. And for those with an ostomy, pouch, or a stoma, certainly there are special considerations to keep in mind, and that, as I mentioned, hernia risk. There is a 10 to 52% increased risk of a hernia following a colorectal surgery. So certainly making sure that we are clearing that and assessing that with, especially with an ostomy, and discussing comfort and fit, assessing skin integrity, trunk strength and stability, and clothing choices, believe it or not, because we want to make sure we're avoiding direct pressure in that area around the stoma or the ostomy as well. And certainly considering comfort and ability related to everyday activities or meaningful activities to that individual, including recreational activities and sexual health activities. Functional mobility assessment, certainly taking into account the person's daily functions, activities they enjoy, want to get back to getting back to. And we want to make sure that there are no physical mobilities or restrictions impacting that as well. Safety with activities of daily living, certainly because there may be balance, endurance, blood pressure changes, sensory changes, neurological changes. All these things are going to impact one's safety. For example, to make it to the bathroom on time, or dexterity issues. Can you remove your clothes enough on time to get to the bathroom, etc. So those are the things that we're keeping in mind as pelvic therapists to support folks with. And then lower body lymphedema screening. So again, we mentioned radiation therapy reduces function of that lymphatic system for the pelvic viscera. So it's important to get that screening. Not every pelvic floor therapist is trained specifically in lymphedema treatment, and referral to a lymphatic drainage or lymphedema therapist is required, because there are a lot of compression garments and fitting and things like that, and that's a whole specialty on its own. Neurological screening, which includes, again, passive and active neurodynamic testing for nerve mobility, especially of the nerves around the pelvis, lower body, etc., but anywhere really that may be impacted by cancer treatment. Certainly lots of education about abdominal, pelvic, sexual health, bladder, bowel function. And then before we even get to the pelvic exam, we're making sure that we have care and consent, and we check in throughout the entire exam to see what that person's more comfortable with as far as engaging in that exam with. And then as far as the pelvic exam itself, we have the genital and perineal observations. We're looking at skin, rashes, redness, abnormal discharge. We're assessing the genitals as far as any perineal or penile deformities. We're assessing reflexes, voluntary pelvic floor muscle activity, so contraction and relaxation, and also being able to push to bear down in order to defecate, for example, would be something that we would be assessing. And then palpation, so feeling these structures and assessing for muscle tone and any provoked pain, diminished sensation or hypersensitivity in these areas, and overall body awareness of function here. And again, certainly assessing any scars anywhere in this area to make sure that tissues that should be moving are moving and that there's no restriction in there. And that could, again, that may include a genital palpation or a scrotal palpation. And then internal assessment certainly is looking at the pelvic floor muscles on the inside. And that does, again, not everyone requires an internal assessment. This is a very unique exam tailored to the individual. I'm just giving you a broad overview of what one might expect here. And certainly if there's been any reduction or changes around the rectum and the anus, we are certainly assessing for any anal stenosis, rectal stenosis, overall tone of the internal pelvic floor muscles, function, awareness, and strength related to that. So certainly sometimes we can use like surface EMG or biofeedback or real-time ultrasound as an overall observation of the pelvic floor. It just tells us about activity, but doesn't really tell us about strength or anything else beyond that. And certainly collaborative goal setting and plan of care, always in partnership with you, not without you, and in a home program that fosters independence, self-efficacy, and is functional, most important, right? It's in conjunction with the meaningful activities you want to get back to doing in your life. And we always have ongoing communication with the oncological care team, including your carers. And then lastly, a brief overview of pelvic health interventions. And I just have to say, I'm looking at the time, it's 7:09, and I knew this would happen because there's so much that I really wanted to share, but so little time. So bear with me, and I totally understand if folks need to hop off due to time, and I respect that. It is being recorded. So, but as far as pelvic health interventions go, certainly, first and foremost, we are educators and we empower folks, really, we empower you to get to do the things that you want to do. Like no activity is off limits. It's more about how can you do that thing that you want to do rather than not doing it or not doing that activity. So again, lots of education around bladder function, urination reflexes, pelvic floor associated with bladder function, and any cancer-related changes that might be impacting bladder function. We may do things like bladder retraining, which includes like talking about hydration, fluid intake and type, reducing potential bladder irritants because of impact on the sensitivity of the bladder itself, a bladder voiding diary, voiding mechanics, for example, making it easier to empty your bladder or neobladder if you have one. So sitting, double voiding, tapping or touching over the bladder areas. And this is a nifty little mini vibrator massage that sometimes people find very helpful to just put on the lower belly or around the sacrum. That can help stimulate neurological reflexes to help empty the bladder a little bit. So we use lots of little tools. We think outside the box. And certainly pelvic floor muscle training or specific bladder urge suppression techniques if appropriate for urinary urgency and frequency. And certainly there are special considerations with the neobladder, certainly because there is an absence of that neurological feedback loop. There's a lack of normal desire to void. If with a neobladder, because it's made with intestinal tissue as a reservoir. And so in this case, voiding does occur with pelvic floor voluntary muscle relaxation. So you have to really relax the pelvic floor muscles in order to void. And that is something that we definitely help folks and train with, also in conjunction with abdominal contraction or using your abdominal muscles, hand over the lower belly, adding some pressure, forward bending, etc. There are some therapists, including myself, that can certainly also assess intermittent catheterization techniques. So if you're having difficulty with catheterizing or intermittent cathing, then that's something that we're making sure that you're able to do comfortably or as comfortably as possible. And then, voiding time intervals, etc. Post-rehab for prostate cancer urinary outcomes. So definitely pelvic floor muscle training is better than no type of training at all. And that's in several randomized control trials. So very cream of the crop type of research. And immediately post-op, as soon as that catheter is removed, in 7 to 10 days, but I've also seen as little as 4 days. So it just depends. And general exercise, here we go again with exercise, adding general exercises without with specific attention towards the pelvic floor muscles can also enhance your results for quicker continence recovery. And then talking about like just like the fun part of everything's the fun part of my job, but I love like sharing with folks the continence care support supplies that are out there, like penile clamps, for example. This is the Pacey cuff. There's also the Cunningham, and we talk about, you know, how to use them with caution, reusable absorbency garments, guards, protective mattress covers, disposable shields. There's also something called Contino, which is a urethral insert, and, you know, addressing hygiene, barrier creams, lotions, and fluid absorbing powders that can help remove excessive moisture from undergarments. So we talk about all of those things. And then bladder retraining is very similar to, bowel retraining is very similar to bladder retraining, but it also addresses certainly the digestive function, absorption, malabsorption, and constipation or diarrhea in conjunction with your nutritionist and nutrition team. So important to have a nutritional oncologist to help support you with the potential negative consequences of cancer treatments all around. But there are different various types of continence care supports, even an anal insert that can help with fecal incontinence. There's also inflatable or anal rectal dilators or trainers, which they look like this. They're a little flexible. They come in different sizes incrementally. And that's used for defecation or pooping retraining, and also to help with rectal balloon sensory retraining as well. So being able to sense when the rectum is full and to help stretch and get flexibility of those tissues to reduce pain and improve function, etc. All right. So sugar, yeah, so I won't, just because of time, I won't go into special considerations for colorectal and anal cancer, but just know that no activities off limits. As I said, even those with ostomies, you can go back to running and swimming and weightlifting and sex and triathlons, etc. Like that is all possible. It's just a matter of having your body adapt to new things related to your body, bodily systems and functions, and certainly being able to be independent with the appliance if you have an ostomy or stoma. And that certainly goes into more detail in an individualized scenario. Breath focus exercises. So it's just that breathing exercises into the belly, the breath focus into the chest, the belly, and the pelvic cavity. It helps to mobilize tissues with your breath, but also to help normalize intra-abdominal or assist with adapting to changes in intra-abdominal and pelvic cavitary pressures, relaxation strategies, and tissue mobilization. Speaking of relaxation strategies, meditation, mindfulness, breathing, awareness practices, heart rate variability training, nature, music, art. I have Play-Doh in my office. I also have a bunch of colored pencils and big paper, you know, because it's so important to connect, again, all aspects of the human experience and that person's goals and needs, and support them in whatever way helps them to integrate all these things in their life. And certainly joint mobility and stretches to the abdomen, pelvis, hips, upper body, lower body, and exercise. Again, the benefits of exercise, I cannot stress that enough. Like during and immediately after, even after radiation therapy, gentle exercise or active assisted range of motion to prevent adhesions, to prevent significant scarring, and also even just gentle strengthening, right? To help with mitigating some of the effects of deconditioning and decreased functional mobility. So, so important again. And this is taken from the American College of Sports Medicine Cancer Guidelines or exercise guidelines, and you all can review that or access that at the cancer_exercise_guidelines. But there's so much strong evidence to support some of the cancer-related fatigue, quality of life, physical function, anxiety, depression, lymphedema that can help with positive outcomes. So much strong evidence and moderate evidence for bone health and sleep. So Exercise, exercise, exercise to whichever capacity and degree you can. Oh, yeah. So I'll go back to some of the other things that we might do. Sensory integration. So sensory integration is really for sensory relearning and processing and pain reduction. We use different textures like this is a sensory brush we might use. It's very soft. I may also use something like a bristled brush or have the person purchase one like this and use that really anywhere in the body that we need to work on. A pinwheel, a cotton swab, or a cotton ball. We may use things like warm or cool cloths or ice, massage balls of various kinds and textures, little nubs at the end of them. Vibration therapy. I already showed you this little massager, but there's also different kinds of vibration therapies, and one, in fact, for penile rehabilitation, for example. This is a guy braider. This can help with sensory, again, reintegration, sensory stimulation, especially if there's decreased genital sensation or there's any type of erectile dysfunction or difficulty. So these nifty gadgets can be very helpful for some. And certainly, manual therapy is also a form of sensory reintegration or integration. And then speaking of manual therapy, certainly scar mobilization, soft tissue mobilization, joint mobilization, and as I mentioned, lymphatic drainage or any secondary lymphedema, but that it has to be with a specialized lymphatic therapist. And then pelvic muscle training specifically, certainly being able to improve function, awareness, contraction, relaxation, range of motion of the pelvic floor muscles and their associated tissues, and certainly strengthening as necessary, not just with local isolated pelvic floor contractions, but coupling that with functional activities and also overloading muscle groups as well. So strengthening your hips, your back, your leg muscles, your lower body, etc. Those are all important as far as synergistic muscle groups that help support the function of the pelvic floor. Pain management. Penile rehabilitation is a specific form of pelvic floor physical therapy. And again, I have a little sadness saying this, but not every pelvic floor therapist is going to address the genitals, especially if specifically with those who are comfortable working with men. And I think I've said that several times already because I've seen it too many times with folks coming to my office and there hasn't been any assessment of the genitals while working with other practitioners. And that's not to say anything bad or negative about anyone else. It's just a matter of comfort and certainly skill and knowledge to address genital structures and things like that. So having these open conversations is very welcome. And certainly a comprehensive exam as well. So penile rehabilitation, certainly penile vibration stimulation using a vacuum erection device like a penis pump, and supporting folks in how do you use a penis pump. And so I actually have people bring their penis pumps in to go over how to use one. And so that I know that they're doing that safely and that we can address any questions, especially like, how do I remove the ring? Those things are, they seem very novel and nominal, but they're not really being discussed in traditional oncological care settings. And so I think it's really important to talk about sexual rehab, penile rehab, however you want to call that, to help with, again, tissue movement, function, flexibility, sexual function, etc. And there's specific different treatments for Peyronie's disease that we use, in particular using therapeutic ultrasound, which is this little ultrasound head, and it uses sound waves that are transmitted from the head of this ultrasound unit to transforms it into mechanical energy. And then we use that as a particular modality to address scarring and adhesions in the genital area. Now, certainly the person has to be cleared with any biophysical agents used by their oncological team before we even initiate such a treatment. And last but not least here is sexuality counseling. So sexuality counseling, again, is something that is not offered with every pelvic floor physical therapist. It is additional training that someone has to go through, extensive training and supervision hours with a sex therapist or a sex counselor. And caveat here, that doesn't mean we are sex therapists or that we are psychotherapists. We are just trained clinicians who are very well versed in having conversations around sexuality health concerns. And it is short-term solution-based counseling that addresses certain sexual health dysfunctions and concerns a person might be having, typically 4 to 6 sessions. And this is where we talk about things like vibrators, penis rings, constriction devices, penis pumps, even couple sexuality counseling of how do we expand the sexual menu, cognitive reframing, offering different sexual resources and strategies as far as rekindling with pleasure and touch and sexual communication and initiation and all of those things, when and if a person and or their partners are ready to dive into that part of their recovery or their rekindling, I should say. So yeah, is there anything else around that? No. Okay. All right. So that concludes. Thank you so much. I know that was a mouthful, really. It was so much. And I appreciate everyone's patience for hanging out with me for an extra 20 minutes here. But if anyone else has any questions, I'll hang around here for sure. I am available. And you can follow me or email me at support@drsusieg.com. I'm also on Instagram, and I have a YouTube channel where we offer educational videos for pelvic and sexual health for men.
That was really incredible. Thank you. So much information.
So much. I know. I just couldn't help myself.
No,
I couldn't help myself.
Great job. A few people have asked if the slides will be available. We won't have the slides available, but we will have the recording of the video that will be up on the website. It'll probably be not in the next couple days, but in the next month or two as the series comes to a close. So you will be able to see the information again. Are there any other questions? You gave them all the information they needed. That's amazing. Good.
I know it can be overwhelming, so I do apologize in advance. There's so much. I mean, how do you fit so much of one's experience and possible avenues to address, persons living with and beyond, cancer's journey? I mean, it's just so much.
So much. But I think you did a really great job breaking down the different components and also just making sure that folks know that pelvic floor physical therapy can be an important part of recovery. So I really appreciate you joining us tonight. As a reminder for folks on the call, there is additional sexual health programming at Life with Cancer, a sexual health support group that runs every month for men, and other educational programming, as well as all around supportive care. So we hope you've learned a lot. I know I certainly have. And we have future presentations from other nationally renowned experts, just like Susie, who will be joining us in the coming weeks. So please tune in, and we'll get this up on the website soon so that people can watch it again. Thank you very much.
Thank you. Thanks, everyone.
Have a great evening.